Hello, and thank you for joining us tonight for our free webinar, Vagal Nerve Stimulation, How, Where, and Why, featuring Dr. Ayla Wolf. My name is Jeff Bloom, Education Marketing Manager here at LASA OMS. I would like to welcome anyone who's joining us here for the first time tonight, and also say a big hello to our frequent attendees. We are so grateful to have you all join us again for another fun night of learning together. For over 40 years, LASA OMS has been striving to promote the growth of the acupuncture industry by providing quality products, great prices, and the best customer service, as well as supporting the many schools and continuing education efforts available. With our free webinar series, we intend to provide free educational opportunities taught by some of our industry's most renowned practitioners and educators. I would like to take a moment to acclimate you to the webinar room. We recommend viewing the webinar in Chrome, Firefox, or Safari, as you can experience slowness in other browsers. To the right of the video screen, you will see 3 tabs: Chat, Questions, and Polls. To chat with other attendees or to communicate any technical difficulties, please use the Chat tab. For questions of the guest speaker, please make sure to use the Questions tab so we see it during the questions and answer time, which will be at the end of the lecture. Please note that each webinar is recorded, and immediately following the conclusion, you will all receive an email with a link to view the video on demand and a copy of the slides. You may always visit our blog and use the free webinar tag to find all of our previously recorded events. From sports acupuncture to Chinese herbs to practice management, you'll find something interesting for every practitioner on the LASA OMS blog. I would also like to mention a great new feature at LASA OMS. We just launched our new LASA Direct program to allow practitioners to recommend products to patients and receive a commission on those purchases. We will share a link in the chat to our blog where you can learn more on how to access this program using your current LASA OMS account. Now for our featured speaker, we are proud to introduce Dr. Wolf. Dr. Wolf is a doctor of acupuncture and oriental medicine specializing in neurological disorders, chronic pain, and concussion recovery. She is a faculty member of the Carrick Institute of Clinical Neuroscience and Rehabilitation. She teaches courses for healthcare practitioners across the country on neurological techniques, functional neurology, and concussion recovery, and has been a featured speaker in veterans groups on the topic of brain health. While in Dallas, Texas, Dr. Wolf was the lead researcher on a randomized clinical trial on the effects of acupuncture on cerebral blood flow velocity in mixed martial arts fighters following concussion. She was the team acupuncturist for the professional MMA fighters at Fortis MMA in Dallas, Texas, working with USC and legacy fighters. And she is now back in private practice. Please join me in welcoming Dr. Wolf.
Thank you so much, Jeff, and thank you to LASA for having me back. I am really excited to share this information with everybody, so thank you for taking time out of your summer evening to join us for this lecture. And today we're going to talk about vagal nerve stimulation, and we'll talk about the different forms of vagal nerve stimulation, but then specifically how we can take the research on that and apply it to our tools, which we all have access to and use on a daily basis. So we'll just dive right in. I have a lot of material to cover here, so we'll...
Hey, Dr. Wolf, I'm sorry to interrupt. We're having a few people comment on the sound. Would you be able to turn the microphone up or move it closer to you?
Is that better?
Let's try it one more time. Do a test.
Yeah, testing.
They said it's not better.
No.
I can hear you perfectly fine, so I'm not sure what the issue is here.
Okay, I can try to speak louder. I have all of my volume on max.
Okay, volume is on max. It says very faint. That's really strange. Can we try it without the microphone, or do you have headphones? I'm so sorry.
That's okay. We can try headphones.
And I will tell you that to me, I hear you perfectly fine. So that's why, we didn't have a problem with the test. But thank you, everybody, for letting us know.
I think my headphones are in the other room.
Okay.
So let me quick grab them.
Okay, perfect. All right. Well, thank you, guys. Just bear with us one moment. We really appreciate you letting us know in the chat so we can get this fixed right away. All right, sorry about that.
Okay.
All right, let's see.
Can you hear me?
I can.
Can everybody else hear me?
Can they say no change? What? Huh. That is really strange. So if you look, if you hover over your face, there's the 3 little dots right there. Oh,
Okay.
People are saying they can hear. They say no change. Huh. Let's try just one thing. So if you click on the 3 little dots, and then it goes into your little, it should bring you into, there's a little settings tab. And then it should, do you see the little settings tab? When you hover over your face, it kind of looks like a flower.
Yeah. Yeah.
Okay, and then when you click on that, it should allow you to select your output for your microphone.
So audio device.
Yep, and is it selected as the headphones or the default input?
I have an external microphone, MacBook Air microphone.
Does it have anything else in the drop-down? Does it have the speaker or the headphones in there?
It doesn't have my headphones. It just has the Samsung microphone.
Okay. Okay, let's try the external microphone one more time, and can you bring it closer? I'm sorry. Well, she'll be back in 1 second.
Okay, how is that?
Oh my God, amazing. I think we're gonna get a bunch of yeses. Okay, all right, I'm jumping off. You are good to go. Sorry about that. Oh, did we lose you again? Oops, coming back. All right, now I'm gonna drop off.
Okay, people can hear me, is that correct?
Hold on, I did the last time. What happened? Can you try it? It seemed to have reverted back. Can you go back to the settings and then select the external microphone one more time? Nope, we're coming back. Don't worry.
Okay. Can you hear me now?
Yes.
Okay. Everybody can hear me okay?
Yes.
All right.
Okay. All right. I'm leaving.
Okay. All right. So we're back. Let me just move right into our material here. So we're going to talk about, again, vagal nerve stimulation and electro-acupuncture vagal nerve stimulation. We'll cover modern vagal nerve stimulation devices that are currently available, and we'll talk about some of the functional neuroanatomy involved in why we would want to perform this therapy in the first place. We'll talk about the proposed mechanisms of action. So, you know, what does happen if we do electro-acupuncture vagal nerve stim. We'll talk a little bit about research and then also how we apply the research to, again, on an acupuncture practice. So for people who are maybe relatively new to neuroscience and neuroanatomy or just want a refresher, I wanted to at least include some slides that talk about what is the vagus nerve, what does it do, where does it go? And I like to start out by just saying the vagus nerve is cranial nerve 10. It's a parasympathetic nerve, and we'll talk about what that means on the next slide. It's also a mixed nerve, so it's containing sensory and motor fibers, which means that sensory information from the periphery, sensory information from our gut, for example, is going to the brain and then being processed. And then the motor fibers are the output of the brain that then go to the heart, the lungs, the digestive tract. And we always talk about the vagus nerve, but I also like to point out the fact that there are really 2 vagus nerves, one exiting the right side of the brainstem and one exiting the left side of the brainstem, as I have in the picture here, where you have the 2 different arrows. And when it comes to the surgically implanted vagal nerve stim devices, that becomes important because there are very specific cardiac vagal fibers that leave the right side of the brainstem and innervate to the sinoatrial node on the right side of the heart and have a certain amount of control over our heart rates. And so is concerned that if you were to do a surgically implanted device on the right side of the neck, it may have some unwanted consequences in terms of altering the heart rate. And so that's why all of these vagal nerve stimulation devices that are surgically implanted are being placed on the left side of the neck. So I like to just point that out. We talk about the vagus nerve, but I like to appreciate the fact that there are two of them. And they, again, leave the right and the left sides of the brainstem, and they both kind of have their unique trajectories as they wander through our body, because the vagus nerve translation is wandering nerve. So that's where that comes from. So when we talk about what parasympathetic tone really means, what people are hearing a lot, and there's a very popular book called The Polyvagal Theory. So lots of people are talking about the vagus nerve, they're talking about vagal tone, they're talking about parasympathetic tone, and I want to really dive into what that means clinically. So when we look at what the parasympathetic functions are of this vagus nerve, well, it slows the heart rate, it decreases blood pressure, controls muscle movements of the throat for breathing and swallowing, and the gag reflex. So it works in conjunction with cranial nerve 9 for the gag reflex. It controls peristalsis of the stomach and intestines, so it promotes the movement of the intestinal motility. It acts on the pancreas to secrete digestive enzymes, so it's really important for stimulating aspects of digestion, regulates insulin secretion and glucose levels in the liver, so it plays a role with not only digestion, but then also regulating blood sugar levels. It balances sympathetic activity to counteract stress and anxiety. Certainly in the world today, there are lots of people that have a lot of that happening. So we're all placing a huge demand on our parasympathetic system to respond to what we are all collectively going through and dealing with as a human race. And lastly, but perhaps not well known, the parasympathetic tone, the vagus nerve, actually suppresses inflammation in the body via a specific cholinergic anti-inflammatory pathway that goes from the brainstem to the vagus nerve. And then there's a branch off the vagus nerve called the splenic nerve that goes to the spleen. And so it's through this cholinergic anti-inflammatory pathway and having active parasympathetic tone in that pathway that actually creates a healthy set point for inflammation. So now we're going to go to the next slide and look at what happens when all of that falls apart. So when we lose our parasympathetic tone, or when we lose our vagal tone, well, now there can be an elevated heart rate, perhaps chronically. We can have increased blood pressure. We can have a diminished swallowing and gag reflex. And we can see that with certain neurodegenerative diseases, like Parkinson's, for example, where we have alpha-synuclein deposits that happen in the brainstem that can affect the output of the vagus nerve, and we can lose that vagal tone in these later stages of Parkinson's and have a diminished swallowing gag reflex. So that's just one example of how that can manifest. And then slowed peristalsis of the stomach and intestines. So when we have decreased transit time, that there's food that's being left in the digestive tract for much longer than it should be. That food can then ferment in the stomach, for example, and create a lot of dysbiosis. So there's all kinds of, downstream effects of what happens when we, lose the proper peristalsis of the stomach and the intestines. And then when you pair that with a loss of pancreatic secretion of digestive enzymes, now you're not breaking down your food very well. And that can lead to leaky gut as different particles, like different proteins that aren't properly broken down, possibly then get into the bloodstream and create an immune reaction. So again, all kinds of downstream consequences of losing proper vagal tone. Decreased insulin and glucose regulations. Now you can have problems with high glucose levels, increased sympathetic activity, increased anxiety, perhaps. And then lastly, increased inflammation due to a loss of that cholinergic anti-inflammatory pathway. So now all of a sudden, when we lose vagal tone, the kind of set point for inflammation in the body actually is higher. And so the amount of systemic inflammation that's allowed to happen goes up as a result of having a loss of this vagal tone. So these are all a big long list of things that are not good. So we're going to talk about how to support people when they have this happening. Again, the vagus nerve innervates a lot of different organs: the heart, the lungs, the spleen, stomach, pancreas, liver, intestines, and kidney. It's called the wandering nerve because it wanders all throughout the thoracic and abdominal cavity and has its hands in a lot of different areas. So now, how does this all come back to the ear? You know, why is everybody talking about the ear when it comes to the vagus nerve? We have an auricular branch of the vagus nerve, and it's also called Arnold's nerve, probably less commonly, but also called Alderman's nerve. So you might hear referred to as a couple different things, but I think the direction of scientific research is going in a way that is taking out all these other people's names or names of places and actually calling it something anatomically related. So more often you'll hear it referred to as the auricular branch of the vagus nerve. And this small branch of the vagus nerve allows us direct access to the vagus nerve through the ear, and specifically through the concha. So we have an inferior concha, which is the lower arrow here, and then we have a superior concha, which people refer to as the Simba concha. And you see an arrow there. So because we have direct access to the vagus nerve through the ear, which is one of the only places on the body where we do have access to the vagus nerve, this has created a growing industry of medical devices that are geared towards vagal nerve stimulation through the ear, and then also some through the neck, as I mentioned earlier. But what's also really important to realize and appreciate is that there are anatomical differences. So when we look at this lower arrow here, pointing to the inferior concha, 45% of people are going to have that part of the ear fully kind of innervated by that auricular branch of the vagus nerve, but 55% of the population has a combination of nerves that innervate the area between the auricular branch of the vagus and the greater auricular nerve. So in 55% of the population, the amount of nerve fibers in that lower part of the ear, where, you know, we're all familiar with needling, say, the heart and the lungs in that area. Well, for 55% of people, yes, that will give us some access to the auricular branch of the vagus, but there's also a ton of innervation from the greater auricular nerve. However, if we look at the top arrow, we see in that superior concha, the Simba concha, 100% of that area is the auricular branch of the vagus nerve. So if we just appreciate this anatomical difference in the human population, we can make the conclusion that it probably makes more sense to needle that Simba concha, that superior concha of the ear, if we want to have the biggest bang for our buck in terms of trying to stimulate the auricular branch of the vagus nerve, because we know that 100% of people, that is the area where it's not overlapping with the greater auricular nerve. Hopefully that made sense. This is just a color-coded version of that, looking at a little bit of that overlap. So we have a lot of nerves. We have a lot of nerves that innervate the ear. We're going to show some more diagrams and talk about more of them. But in the blue part on the top of the ear, we have the auricular temporal nerve. That greater auricular nerve innervates the large majority of the ear. And that auricular branch of the vagus in purple is really located in that Simba concha, or in that concha area of the ear. So that's where we want to access it. And then I have this ear on the left that just talks about some of these overlapping areas. So it's not as straightforward as one might think. And like I said, there are differences from one person to the other. So not only are people's anatomy different in terms of the innervations and the overlap of different nerves in the ear, like we just talked about,
but the ratio of C fibers to A beta fibers within that auricular branch of the vagus nerve also vary widely between people. And so C fibers transmit predominantly pain, and A beta fibers more sensory information that's not in the painful category. And for this reason, because some people might have a higher ratio of C fibers to A beta fibers, and we've all seen patients who are just like over the top sensitive to auricular acupuncture, and then there are other people who are kind of like, no big deal, right? Well, that's what's happening. This ratio of C fibers to A beta fibers is different for everybody. And so if we have somebody that has a certain ratio that might be favoring more of the C fibers, they might actually not respond as well as somebody that has a higher ratio of A beta fibers. So what I like to just point out is that if one of your patients doesn't respond so well to electro-acupuncture in the ear, don't blame yourself. It might be just because they have anatomical differences, and for those reasons, for those ratio differences, they just might not have as much of a therapeutic effect to what you're doing. So I like to just throw that out there, that there's not ever one protocol that is 100% effective on 100% of the people, and it's nice to know why. All right, so if your mind just short-circuited on this slide, don't worry, this is why I have arrows. These are all the different nerves that are innervating the ear and around the ear. So you can see there's a lot going on. And let's just start with the red arrow on the far left here. So what I want to point out with this red arrow is that the auricular branch of the vagus nerve, this tiny, thin yellow line, actually connects to the facial nerve, which is this giant, big, fat nerve here. So we have a connection with the auricular branch of the vagus to the facial nerve, cranial nerve 7. And then if we go down here to the green arrows, the auricular branch of the vagus nerve also links up with the glossopharyngeal nerve, which is cranial nerve 9. And of course, it links up to the vagus nerve, cranial nerve 10. So that auricular branch of the vagus nerve, that little guy actually connects to not just the vagus nerve, but it connects to cranial nerve 7 and cranial nerve 9 as well. And that's going to become important when we talk about what happens in the brainstem and then the central projections from the brainstem when we stimulate that auricular branch. So let's just talk first, let's just define what vagal nerve stimulation is. It's a process of stimulating the vagus nerve in order to increase the vagal tone, or parasympathetic tone of the autonomic nervous system. And vagal nerve stimulation can be performed on the ear and then also on the neck, because the vagus nerve goes through the neck like we saw in that picture in the beginning. And so current devices that are on the market are surgical implants. I have a slide on that. And then we have transcutaneous vagal nerve stim devices, where they're running current on the surface of the skin to stimulate the auricular branch of the vagus nerve. And they also have transcutaneous for the neck well. And then percutaneous, where you're actually inserting a needle through the skin to stimulate that vagus nerve. And then we have, in our profession, electro-acupuncture vagal nerve stimulation techniques as well. So when we look at surgical devices, again, I mentioned they're implanted on the left side of the neck, and then there's a programmable pulse generator that gets implanted in the chest wall, and then these little tiny electrodes are wrapped around the vagus nerve on the left side of the neck. And so each time that generates a pulse, it creates an electrical stimulation of the nerve in the neck, and by stimulating that vagus nerve neck, you're increasing the tone of the vagus nerve. So there are possible side effects of any kind of surgically implanted device, but during implantation of the device, people can possibly have bradycardia, asystole, post-operative, they can have peri-incisional hematomas, they can have difficulty with breathing, localized infections at the surgical site. And then longer term, 2/3 of patients that have these devices implanted have transient dysphonia. So they have kind of changes in their voice that come and go. And then other side effects can be paresthesias or pain as a result of implanting that device. So, any surgery, obviously, that's invasive like this carries the possibility of having side effects. This is definitely an invasive surgery, but it is FDA approved for severe depression and also epilepsy. So, if people have tried many different medications for treating epilepsy and none of them have worked, it makes sense to try something like this. I imagine that as the research continues and progresses, what these devices are FDA approved for is going to change dramatically, and it might start to be approved for a lot of different situations. Right now, these are the two that it is approved for. And then we now have these transcutaneous vagal nerve stimulation devices. So what this one is, this is called the gammaCore. I believe that's the one that's pictured here. So the gammaCore is approved for use by the FDA for the prevention of migraines, specifically in the United States. And it uses a 25 hertz milliamp sinusoidal wavelength. So people put a gel on those two metal probes on the top of it, and then they place it on the neck in the area of the vagus nerve, and it delivers those 25 hertz milliamp pulses to stimulate the vagus nerve through the neck. So that's a version of a transcutaneous device. There are a lot more that are on the market or coming out, so this is just, again, one of them. And this is an example of a transcutaneous device that plugs into the ear. So that little clip that you see actually goes in the ear. And this one, the Parasym, is available in Europe. So again, just another example of what some of these devices look like. And then this one's a really interesting one. This is a percutaneous vagal nerve stimulation called the NSS2 bridge. It's approved for opiate withdrawal in the United States as of 2017. And I believe the same company has a military version of it, but the information is not readily available on their website. So I can't say more about that, but it sounds like perhaps in the military they're also using a device similar to this. So the little pads that you see taped to a couple different spots on the ear actually have needles in them. So that is a percutaneous one because you're putting these needles into certain spots on the ear. So this percutaneous nerve field stimulator electrodes are embedded in the skin to specifically target the trigeminal nerve, greater auricular nerve, glossopharyngeal nerve, and that auricular branch of the vagus nerve. So that's the NSS2 bridge. And then when it comes to auricular acupuncture and the use of electro-acupuncture for vagal nerve stimulation, again, we're seeing a lot of people starting to talk about this for all kinds of issues, anything from general stress and anxiety to the treatment of depression, high blood pressure, any kind of gut dysfunction, migraines, pain, and addictions. Obviously, the benefit of this is that it is not an invasive surgical procedure. However, unlike wearable devices that people can have at home, people would actually need to go in for regular electro-acupuncture sessions. So, that is kind of a downside. If somebody can have access to a device that they can use every single day for really serious conditions, that might be what they need. But for other people, they might respond, really well to being able to come in 2 to 3 times a week to receive a vagal nerve stimulation electro-acupuncture treatment. And again, I just want to point out that where this needle is inserted is in that Simba concha. So I have a picture here of the needle. It's very much in the same region as the large intestine auricular acupuncture point. And we'll talk a little bit more about some correlations with that particular point towards the end. This is also a really nice chart just showing that when you're stimulating, if you look at the picture on the left, you're stimulating all of these nerves in the ear, and then they have these corresponding nerves that light up as a result. So the green, and I'm sorry if it's not super clear, I tried to kind of blow this picture up as much as I could. But the green is the trigeminal nerve. The orange is that vagus nerve that's just going straight down the neck. The dark purple is the glossopharyngeal nerve. And then it's hard to see the pink one, but that's a specific intermediate branch of the facial nerve. So just a really nice visual of kind of where these nerves are, what they look like, and the fact that when you use a stimulation and you're activating all these different nerve fibers and nerve endings that are going to the ear, it doesn't just activate the auricular branch of the vagus, but you can have a lot of other nerves that are stimulated as well based on where the needles are placed and how many needles and these kinds of parameters. So when it comes to all these different vagal nerve stimulation devices and things, what I really want to point out too is that this is not theoretical anymore. The vagal nerve stimulation has been extensively researched. Obviously, any kind of medical device that has been approved by the FDA that's either being surgically implanted or used on the neck. These companies producing these devices have to prove the utility of the device, the effectiveness of the device. And so this is one of those areas where we may not have a huge body of research specifically on electro-acupuncture in the ear. But we have a huge body of literature looking at these transcutaneous vagal nerve stimulation devices in the ear. And we as a profession can use that research that's been highly funded and very well studied and published, and we can translate that into what we do. I'm not saying there are no acupuncture studies, but what I'm saying is there are many more studies that are looking at these other devices. And it's the same thing for median nerve stimulation devices too. There are a lot of electro-median nerve stimulation devices over, that you would place right over pericardium 6, for example. And so while we may not have tons of large studies on pericardium 6 and electro-acupuncture, we can look at all this amazing research that talks about this median nerve stimulation. And what they're finding when they use these other devices to stimulate the median nerve. So we're at this point now in research and in medicine where there's so much crossover between all these different disciplines and between all the different technologies that, if we start to look outside of our field, we can find a lot of research that is still very valuable to what it is that we do. So that's what I'm trying to bring to kind of to the forefront of the information that's available to us. Looking at it, explaining it, and then learning how we can apply that in practice. So these things isn't theoretical. Vagal nerve stimulation, there are specific brain areas that are associated with these central projections of the vagus nerve. So that's what we're going to get into. And what that means is that once the vagus nerve afferent information enters the brain, it goes into a very specific area called the nucleus tractus solitarius. And from there, we have these known central projections of that nucleus tractus solitarius to other parts of the brain. We know what other areas it communicates with. And so because we know this information, we can do stimulation on the ear, do the brain MRI, and look at what parts of the brain light up. And if those parts of the brain match up with these known central projections, then we now have that research that says, aha, if we stimulate that auricular branch of the vagus nerve, we know that nucleus tractus solitarius is being activated, and then it's signaling to these other higher cortical areas and creating, a modulatory effect on them. So that's what we're going to get into next. So let's talk about the nucleus tractus solitarius. Let's break this down a little bit. So the NTS is part of what I just called the vagal complex in the brainstem. The vagal complex is a number of different structures that we're going to talk about. And so the NTS has these inputs, and we've already talked about them. We've talked about cranial nerve 7, cranial nerve 9, and cranial nerve 10. So all three of those go to nucleus tractus solitarius. They bring afferent information to the NTS. And then once the NTS is activated, it then has projections. One of those projections is what's called the pontomedullary reticular formation. A big mouthful, but I'm going to keep it super simple and just say that when this pontomedullary reticular formation is active, it's really involved in the parasympathetic output of the brain, of the nervous system. The NTS also goes to the paraventricular nucleus of the hypothalamus. It goes to the visceromotor centers of the thalamus. So it goes to hypothalamus, thalamus, and then it's to the insular cortex. I'm sorry, that is a typo. It should say insular cortex. And it goes to the amygdala, which is part of the limbic system. We're going to spend some time talking about the insular cortex because I feel like this is one of the structures in the brain that is the least appreciated. And so we're gonna talk about it. We're gonna give it some love here. But first, I'm gonna reintroduce this horrible picture just to show that, again, that auricular branch of the vagus nerve, when you stimulate it, it's connecting to the facial nerve, it's connecting to cranial nerve 9, and it's connecting to cranial nerve 10, the vagus nerve. So it's connecting to all three of those. And as we just went over, all three of those then go into the nucleus tractus solitarius in the medulla. So when we're stimulating that auricular branch of the vagus nerve, we're actually not just stimulating the vagus nerve. We're doing a lot more than that. And so I tried to draw this out in a way that is a little bit more visually appealing than the previous slide. So what I have here, starting on the far left, is, again, we have these two main branches of the auricular branch of the vagus nerve. We've got a branch going to cranial nerve 10, we have a branch going to cranial nerve 9, and then we have this connection between the auricular branch and the facial nerve. All three of those go into the NTS. We know that NTS stimulates or, has an impact on what's happening in the limbic system, the amygdala. And then we also know that it's going to that PMRF and the parasympathetic output through the dorsal motor nucleus of the vagus, which is the motor output of the vagus nerve or vagal complex in the brainstem. We know it goes to the hypothalamus and the thalamus. So the hypothalamus, again, a lot of important things happening there in terms of top-down inhibition of pain, for example, and also lots of neuropeptides and neurohormones being released. Thalamus, very important for gating information. And then the insula, which we're going to spend some time talking about why that's important. And then what I have here is just pointing out that all these structures also go to the prefrontal cortex. So when we create more stimulation of that nucleus tractus solitarius, we're also going to then create more activation within that prefrontal cortex as well. And then to bring it back around to the whole circle of everything, when we have this parasympathetic output, that means that we're having that parasympathetic tone that's affecting all of our internal organs, like we spoke about with the stomach and the intestines and the spleen and glucose regulation. And then because the vagus nerve is a mixed nerve of sensory and motor, all of the organs are feeding that sensory information back to cranial nerve 10, and then cranial nerve 10 feeds it back to the NTS. So again, I'm trying to make some extremely complicated connections seem a little bit more easy to understand with some basic boxes and arrows. So hopefully I accomplished that. All right, so I always like to ask basic questions and make sure that I know the answer. So if we talk about, what causes a loss of vagal tone in the first place, why is everybody talking about vagal nerve stimulation? So let's talk about that. We've got a couple of different angles here. So one angle is information going from the gut to the brain. And I've heard that 80% of the information in the vagus nerve is sensory information going from the gut and the internal organs to the brain. So 80% is a big part of the pie. So if there's an unhealthy gut microbiome that's leading to immune-mediated cytokines and neurotransmitters in the gut, these can alter the signaling of the vagus nerve to the brain. So essentially, real simply, a poor gut microbiome can actually impact how much information is being sent from the gut to the brain via the vagus nerve. And so that's one half of the story. The other half of the story is that our brain is in charge of this motor output of the vagus nerve. So we can have dysfunction within the brain causing dysregulation and a loss of integrity within the autonomic nervous system. And then that leads to that poor motor output of the vagal motor complex in the lower brainstem. Now, because I work with people with traumatic brain injuries, I see this all the time, that after a traumatic brain injury, people develop all kinds of digestive issues, whether that is heartburn, whether it is constipation, whether it is all kinds of new food sensitivities. So many of my patients, after their concussion, by the time they get to me, whether that's 6 months later or two years later, many of them have said, yeah, I've already had, I've had to cut out gluten, and I've had to cut out corn, and I've had to cut out, all these different foods. And a lot of them never really linked it to their brain injury because it wasn't a sudden onset. It was more of kind of a gradual onset. And especially in the case of perhaps what might be considered a mild concussion, for example, some of these people just, they don't even connect the dots. But I see it very frequently in my practice that many people with brain injuries develop certain gut pathologies. I have also seen people develop all kinds of issues with blood sugar regulation and poor blood sugar control as a result of the brain injury, and the vagus nerve has a lot to do with that. So we have to appreciate that that's not a one-directional thing. It's not always just throwing a ton of supplements at somebody and hoping it'll fix the problem. We have to realize that, it's not only what's happening with the gut signaling to the brain, but whether or not the brain is appropriately signaling to the gut and creating that healthy vagal output of the brainstem. So I want to just read this. This was a great paper that came out in 2018 called The Vagus Nerve as the Interface of the Microbiota Gut-Brain Axis. And what I really like is that they didn't just call it the gut-brain axis, they called it the microbiota gut-brain axis, because so much of what's happening in the gut is dependent upon having healthy ratios of different colonies of bacteria. So the gut microbiota is a very important aspect of overall gut health as well as overall brain health. So what they say in this paper is that stress inhibits the vagus nerve. So that's important to know. Stress inhibits the vagus nerve and has a deleterious effect on the gastrointestinal tract and on the microbiota, and is involved in the pathophysiology of gastrointestinal disorders, such as irritable bowel syndrome and inflammatory bowel disease, which are both characterized by a dysbiosis. A low vagal tone has been described in both these disorders, thus favoring peripheral inflammation. And targeting the vagus nerve, for example, through vagal nerve stimulation, which has anti-inflammatory properties that we've talked about, would be of interest to restore homeostasis in the microbiota gut-brain axis. So just a really nice summary, I think, of everything that we've covered so far. So I've mentioned that there's a lot happening with this vagal complex in the medulla. So I'm going to break this down into a couple of different nuclei. So we've got these vagal motor projections. This is the efferent projections, the motor output. And we have the dorsal motor nucleus of the vagus. Sorry, it's kind of a mouthful. So this motor output innervates the lungs, the heart, the stomach, spleen, intestines. And then we have the nucleus ambiguus, which innervates the larynx and esophagus and is responsible for the swallowing and the gag reflex. And then we've got our sensory projections. So these afferent areas that are taking in all the sensory input from the internal organs and then the spinal cord in the case of that spinal trigeminal nucleus. So we've got the NTS that we've already talked about and the different cranial nerves that go in there. And then we have the spinal trigeminal nucleus. That's also a sensory aspect of the vagal complex. And so that is actually in kind of that lower medulla, but also into the spinal cord. So this is our kind of the complex that we're paying attention to here. So to go back to that question of what causes a poor vagal tone, we can have, again, this is more of my, my visual diagram of that, where all these red X's are areas where we could have problems. So we could have a problem with the gut and the gut microbiota, essentially decreasing the amount of sensory information going into the NTS. We could have a brain injury affecting some of these higher cortical structures that then mean that those higher cortical structures are not activating that lower brainstem, and that can lead to this poor output on the efferent side of things. And then what we haven't talked about yet is the fact that the cerebellum also plays a really important role in activating that lower brainstem. And so if there is an injury with the cerebellum, or if there's some kind of decompensation of that cerebellum, and especially some of these midline structures of the cerebellum, that can also mean that we have decreased motor output of the vagus nerve. So this is just, again, a really simple diagram saying that there can be problems happening in different places, and it's not just a straightforward matter of, let me just throw some probiotics at this patient and hope that they get better. It's not as simple. So, but what could be simple is if we do auricular acupuncture in the ear, we're going to create, with the electricity, we're going to stimulate the auricular branch of the vagus nerve. So when we create more activity, we're going to create more information going into the nucleus tractus solitarius. We are also going to create more activation of the vagus nerve directly, because that auricular branch of the vagus nerve connects back up with the vagus nerve itself and increases activity of that peripheral nerve. So just by doing the auricular acupuncture, the electro-acupuncture in the ear, we're going to create more input into the brainstem. We're going to create more activity of the actual peripheral nerve, the vagus nerve. We also have fMRI research showing that there can be increased activity of the insular cortex and the prefrontal cortex. So when we have more activity of the insular cortex and the prefrontal cortex, that also then creates more stimulation and more output of that pontomedullary reticular formation and this overall output of the lower brainstem in terms of vagal tone. I have not yet read any research looking at vagal nerve stimulation and its effect on cerebellum, so I can't comment on that from a research perspective at the moment. But this here at least looks quite promising. So I've been talking about the insular cortex, so let's talk about it a little bit more. And then we're getting towards the end of things here, so I'll be able to wrap this soon. The insular cortex is located deep in the brain, so that's why we have kind of this carved out area of the brain in the picture. So it's at the junction of the frontal, temporal, and parietal lobes. And, you know, one of the really, really important questions that people maybe never think about is, where does it all start? Meaning we have this autonomic nervous system, right? So we have an autonomic nervous system, but all of this information, the sensory information from the nucleus tractus solitarius and all the sensory information going up the spinal cord, well, yes, it's going to the parietal lobe, but the parietal lobe is not where our autonomic nervous system, you know, functions. That's not really an aspect of it. So what's really been, I think, missed on a global level is the fact that there are tracks that go from the nucleus tractus solitarius to the insular cortex and give it all of the sensory information it needs. And there are tracks on the spinal cord through the thalamus that also go into the insular cortex that tell the insular cortex about what's happening in the entire body. So when it comes to the autonomic nervous system, the insular cortex is actually at the top of that system. The insular cortex is the area in the brain that is receiving information about pain and about temperature and deciding what kind of autonomic response to have. So I think that's pretty important. So it all starts there. And the insular cortex has, different distinct areas. So the posterior part of it receives all of that sensory information in a somatotopic fashion. So just like the parietal cortex has a sensory homunculus, the insular cortex has its own sensory homunculus. And it takes all that information on pain and temperature and what's happening with all of the internal organs, and then it forwards that information, it processes it in the anterior part of the amygdala, and then it forwards that information onto the prefrontal cortex. And then from there, it goes through the whole cascade of the autonomic nervous system. So the insular cortex is actually very, very important. It's also where we have a specific sensory homunculus just for the gut and the entire digestive tract. So when it comes to things like irritable bowel syndrome, like we mentioned earlier with that research paper, irritable bowel syndrome is essentially a sensory processing disorder of the insular cortex. And it's a chronic pain pattern of the gut. So again, this is part of this part of the brain I think needs a lot more attention. And one of the reasons why I like it so much is because acupuncture is very good at activating the insular cortex. So one of the things that the insular cortex is really truly responsible for is this aspect called interoception. So before I get into what that means, I found this paper. It's a 2020 paper, and I absolutely just flipped out with excitement when I saw this, because it's showing here that we don't just have a sensory or a sensory homunculus in the parietal lobe, but we also have our frontal, our motor cortex has its own homunculus, but the insular cortex has its own homunculus. But what's really important about all this is that these are all different. So in the parietal lobe, we have our classic sensory homunculus that we were all familiar with, where the hands are really big and lips are really big. But if you look at the insular homunculus, there's actually more representation of the chest and the abdomen and the internal organs. And so I just thought that this diagram was so beautiful in showing that we have all the different maps of the body in our brain, but each map is different based on what that part of the brain is supposed to do. So obviously with our motor cortex, we want a huge representation of what the legs are doing, right? Because that's important in terms of motor function. But when it comes to the sensory or the autonomic nervous system, the legs are teeny tiny in the insular cortex. It's more about what's happening in the gut and the chest and the face. And so anyway, I got so excited when I saw it. Super excited to share that with you. Now let's move on to this idea of interoception. So when we ask somebody, how are you today? How do you feel? How are you doing? What are people basing their answer on? A lot of different things, right? People are basing their answer on so many different things, but there's almost like this mental calculation that happens where somebody is like, how do I feel today? And am I too hot? Am I too cold? Does my stomach hurt? Did I eat something and that's bothering me? Is my heart beating too fast? This interoceptive awareness is the ability to feel the condition of all the tissues in our body, and then have overlaid on top of that our emotional state feeding into all that. Because we all know that when we have strong emotions, those affect our heart rate, they affect our digestion, they affect our stomach and our gut, and everything is so closely linked together. So this interoceptive awareness of our feelings, our emotions, our internal body, our external musculoskeletal system, our temperature, this is all happening. It's all being integrated together into the insular cortex. So that's why it's so important, because if we can do something to modulate that insular cortex and how it's processing all of that information, that's what is going to have a huge impact on how somebody feels. It's really quite astounding. So the insular cortex allows us to be aware of all of our bodily sensations. It's where we are aware of our feelings. It's also where we get a subjective sense of time. And obviously, like when we're happy, time seems to just fly by. We're not paying attention to it. But when we're sitting in a lecture requiring a massive amount of brain information, some of you might be looking at the clock being like, man, like 55 minutes seems like a long time. So thanks for sticking it out with me. But also energy, self-regulation, subjective feelings of fatigue. So the insular cortex is actually where we are processing how energetic we feel. And I've been watching that show TV Alone, where they, drop people off in the Arctic and they have to, catch rabbits and, be by themselves for 3 months at a time. When I'm looking at that, I'm like, man, these people are in the Arctic. It's freezing. They're starving. They have no support. And so it's like the person with the healthiest insular cortex is the person who's going to win that show. I'm pretty sure. I would bet money on it. So the insular cortex, it's really important. And the whole point of talking about it is that when we do acupuncture, electro-acupuncture, and activate the vagus nerve, it creates activity in the insular cortex and it actually brings more balance to the insular cortex. And as a result, people feel better. So because we're running out of time, I'm actually going to skip over this. But all I want to point out here on this slide is if you look at the electro-acupuncture parameters, this research on transcranial vagal nerve stim, a lot of the research is using either 8 hertz or 25 hertz, and they're using discontinuous frequencies. So if we look at that research and we try to summarize it, basically the research is saying they're using that Simba-Concha. They're seeing that Simba concha or superior concha is more biologically active as a site to stimulate, as opposed to the inferior concha or even the inner wall of the tragus, which is another part of the ear that's been researched. And they're using 8 or 25 hertz milliamp, and they're using discontinuous settings. So that's what we're going to apply to electroacupuncture. So when we do electroacupuncture, we want to use that Simba concha or that kind of equivalent of the auricular large intestine point. We want to use 25 hertz milliamp and probably discontinuous or an intermittent setting if we want to model what most of the research is doing. And then my recommendation would be, since we can't send people home with this and they can use it every day, you probably want to have somebody coming in at least twice a week, if not 3 times or more, for at least a 20 to 30 minute session. And then this is just a slide showing what's called a daith piercing. So the yellow arrow is pointing to the daith, the piece of cartilage that's called the daith. So a daith piercing is used to treat migraines. And I have heard, a number of anecdotal case reports of people having huge success with getting a daith piercing and having less frequent migraines or having their migraines go away completely. Obviously, this is not a 100% cure, and the effectiveness of it might also depend on the exact location of the piercing and the skill of the person doing the piercing. But it's very similar to the same area of the large intestine point, and it's also obviously kind of in that superior concha, that Simba concha area. So fascinating to just pay attention to and see the similarities. So the title of this lecture was, vagal nerve stim, how, where, why. So to summarize, the how. Vagal nerve stim stimulates the auricular branch of the vagus nerve, which increases overall vagal tone through increasing activity of the vagus nerve directly, and then increased activity of the nucleus tractus solitarius and its central projections. The where is that superior concha, which is similar to the auricular large intestine point, electroacupuncture, 25 hertz milliamp, and discontinuous setting. And the why is that increasing vagal tone may benefit patients suffering from depression, anxiety, chronic pain, inflammatory disorders, gut disorders, migraines, insomnia, addictions, chronic stress, and more. real quickly, I have basically an expanded version of this coming soon to my website, but I also have other classes on my website, acupunctureneurology.com, that go into a lot of the neuroanatomy and neurophysiology of acupuncture, Chinese herbs, understanding what happens when we needle cardium 6. I have a whole course on migraines. So lots of fun stuff on my website, all NCCAOM approved. And these are my references that I used. And in other global news, Taoism goes intergalactic in 2020. We now have crop circles of the yin-yang symbol with some alien additions to them with some outer rings. So I was very excited to see that. I thought we could all use some positive news. And that is all I have for you today. Thank you so much for hanging in there. I know it was a lot. So I'm very appreciative. Thank you.
No, thank you. That was amazing. And everybody there's so many questions. So I probably shouldn't even take any extra seconds.
All right.
So bear with me a moment. It's just loading because that's what happens when there's a lot of them. First question, would using massage, acupressure, or seeds be a workaround to get better results for people with a higher ratio of C fibers?
Oh, what a great question. I don't know how strong seeds or massage would be in terms of getting enough stimulation into the vagus nerve to make a clinical improvement. So like I'm often tell my patients to massage the inside of their ears. It is like a homework assignment that I do give a lot of people, but I just don't know if it's strong enough. I mean, the electro-acupuncture with the milliamp is so much stronger than just touch. So I just don't know because I haven't seen the research, but I like how people are thinking about that, especially with that C fiber to A beta fiber ratio. So again, I give that as a homework assignment to my patients. I don't know how powerful it is for, say, activating the insular cortex, but I think it's definitely a good, it's not a bad thing. I can say that much.
All right. Next question. When we do the nada points, we needle the sympathetic parasympathetic point. Is this the same as needling the vagus nerve in the superior concha?
So when it comes to activating the specific auricular branch of the vagus nerve, like I said, the large intestine point is going to get you into that superior concha. With the nada protocol, you're still getting into the inner concha with your lung point and your kidney point, your liver point. So I do still believe that the nada protocol does have a certain amount of activation of the vagus nerve. However, a lot of the research again is saying that if you use electro-acupuncture, you're going to get a much stronger effect. So again, I've used the NADA protocol for a long time, and what I will say is that I am now switching, and instead of using the NADA protocol, I'm using electro-acupuncture at this large intestine point, and I also will throw in like Shenmen and point 0. So I'm also using other auricular points in my treatments, but I'm doing electro-acupuncture specifically on the large intestine points.
All right. How well does microcurrent point stimulation work? And then also, how about needle devices such as the dolphin device?
So, sorry, the first one was microcurrent?
Yep.
Okay. In terms of stimulating nerves, I do think microcurrent has a lot of activity happening at a cellular level. But I think that your milliamp settings are, again, going to probably have a stronger impact on activating certain areas in the brain. So that's just where I've seen most of the research going in terms of the difference between microcurrent and milliamp is in what you're seeing happen in the actual kind of higher cortical structures, such as that insular cortex. And then the second part of that.
So to use a stimulation device that doesn't connect to a needle. Yep.
Yeah. I guess it would depend on how long you're using it. I mean, I have a Pointer Plus, but I'm only using it to find the points. I'm not using it to sit there for 30 minutes and stimulate a point. So that's why I like the electro-acupuncture device, where I can just hook it up and then, you know, do other things. Because with the dolphin, my understanding is you would have to sit there and hold it on the point. And I think that when it comes to the dosage and the frequency and the time, those are really important factors for having some neuroplastic changes happen within the central nervous system. So if you're just using a dolphin or a pointer plus and you're only stimulating a point electrically for, say, you know, 10 seconds, 20 seconds, 30 seconds, I don't think that's going to be a strong enough dosage to make that kind of neuroplastic difference within those higher cortical areas.
All right. Moving on to the next question. What if any percent of the tragus is innervated by the auricular branch of the vagus nerve? The
inside of the tragus is. And the research, the research on that says that that is another very possible point to needle. Me, I just find that the Symbicontia is easier to access. So for the just kind of the ease of the technique, I prefer that area of the ear, but that inner inside wall of the tragus is innervated by the auricular branch of the vagus as well, and is definitely a valid real estate area to activate it.
All right. What are contraindications for electroacupuncture of the vagal nerve stimulation?
So that's a really good question. Obviously, these medical devices have been approved for epilepsy. I personally, when I have a patient with epilepsy, I don't use electroacupuncture, and maybe I'm being overly cautious, but I'm okay with that. So when I'm treating someone with epilepsy, I actually am not using electroacupuncture on the head or the body, just totally out of, you know, caution, I guess, a certain healthy amount of caution, even though these devices are FDA approved, or the surgically implanted devices are FDA approved for epilepsy. So I'll leave that one up to kind of those people who are doing the surgeries. Other contraindications, you know, I can't really think of other ones. Obviously, when I'm working with pregnant women, I'm not trying to overly stimulate nerves. So with pregnant women, I would not do electroacupuncture vagal nerve stim, just again, as to be overly cautious in my practice. You know, people with pacemakers, they say that you can still do electroacupuncture with somebody that has a pacemaker, as long as you are not having any electricity kind of going through the chest or the heart area in terms of where the needle placements and the leads are. So in terms of, you know, pacemakers, just be aware of that. So I would say those are obviously the big ones. And then if people already have like a spinal cord stimulator in, I also I don't like to mess around with electroacupuncture when people have these other spinal cord stimulators.
All right. You might have already answered this, but I'm going to ask it anyways. What are the optimal frequencies for auricular electroacupuncture?
So in the research, and again, the paper that I was reading, really pulling out some of the best research. It was a review of kind of all the different studies. So the most common ones were 8 hertz and 25 hertz milliamp. Now, my machine that I use doesn't have an 8 hertz setting. And so I use 25 hertz because I have a setting for that. I did recently see a paper that was looking at 100 hertz as a setting. I have not used that in practice, so I can't really speak to that. So that's why I would say, as just a nice rule of thumb for starting out right now, and based on the research we have to date, that 25 hertz milliamp is probably a good setting to stick to.
All righty. Let's see. Can you also speak to problems or issues with overstimulation of vagus nerve, as well as, well, you already spoke to contraindications, so we answered that part. So how about just overstimulation of the vagus nerve?
Yeah, so there's a neurological exam technique that I use called the baroreceptor reflex. And what's really great about that technique is that you can actually have objective kind of measurements of sympathetic output in the body versus parasympathetic output. And so when I do that baroreceptor reflex test, it actually gives me an indication as to whether somebody has low parasympathetic tone or not. And if they don't, then I'm not going to try to stimulate the sympathetic nerve if I'm seeing that it seems to be responding just fine. So I talk about that more in my class where I go into this, but it's a great question, and so I'll cover it right now just because I think people are probably interested. So with that baroreceptor reflex, you need a heart rate monitor. So I have one that has a finger sensor. So I put the finger sensor on their finger. I'm watching their heart rate monitor. I apply pressure to the carotid artery in the neck. When you apply pressure to the carotid artery, you're increasing blood pressure in that artery, and so you should see the heart rate drop. So if somebody has a healthy sympathetic output, the heart rate's going to drop right away, about 5 to 8 points. And then once you see that drop, you take your fingers off of the pulse. And if somebody has healthy parasympathetic tone, you'll see heart rate immediately start to go back up to where it was when you started. So if you start at heart rate of 70, you apply pressure to the carotid, you should see the heart rate drop, maybe down to 65. And then you take your fingers off and you should see the heart rate bounce right back up to 70. So if you take your fingers off and you're watching the heart rate monitor and nothing's happening and their heart rate is staying depressed, now you know they have low parasympathetic tone and you've got a green light to do your treatment.
All right. Sounds like they should still take your class. Let's see. Would this help for age-related hearing loss?
I don't know the answer to that question because I haven't seen any research specifically looking at the auricular stimulation in terms of the auricular branch of the vagus nerve and hearing loss. I do believe that you could certainly have make a change in someone's hearing using some other acupuncture points, but specifically this treatment, I haven't seen any research and I don't use this for that specifically. And then I do see in the chat room, someone was asking about unilateral versus bilateral. And I use bilateral auricular ear points at the same time to answer that question.
Okay. And somebody had said that you can't do electrostim on both ears at the same time. Is that true?
So in speaking to people who actually make electro-acupuncture devices, they have said that it is okay to do both ears and hook them up to one lead. So people who actually make these devices have said that is okay to do. If somebody does not believe that or doesn't want to do that, they could certainly do the large intestine point and the lung point and hook those up to one lead and then hook up the large intestine and the lung point to a second lead.
All right. And the next question, I've heard you can overstimulate the vagus nerve. Can you, let's see, the comment wasn't specific to acupuncture or implanted devices, but can you still comment on that?
Yeah, I always like to say that anything that has a therapeutic effect can have the opposite effect when used at the wrong time on the wrong person. So yes, that's why I like that baroreceptor reflex test, because if I see that the person's parasympathetic tone is fine, and I'm looking at the rest of their clinical picture as well in terms of like a more complete neurological exam, everything that I'm seeing in my neurological exam is going to feed into why I would or want to do vagal nerve stimulation. So, and that's maybe a much larger conversation than tonight. But, again, everything that has the strength to make a change in one direction can also perhaps overstimulate as well. So you would want to be careful with that and really pay attention to people's vital signs, their autonomic signs, looking at heart rate, blood pressure, sweating, all of these things, and pay attention to all these signs and symptoms and signals that might tell you maybe this is too much for that particular person.
All right. Are those that are super sensitive to auricular needling predominantly C or beta nerves?
So just from what I understand about nerve physiology, I would think that they probably have a higher concentration of the C fiber in that auricular innervation.
All right. Do you find some people are already too, do you find that people are already too parasympathetic for whom VNS is not helpful or even contraindicated?
Yes. So just because there are lots of people that are focused on, increasing vagal tone, that's not to say that there aren't people who don't need that. And some people do have increased parasympathetic output for one reason or another. And then, yes, I would not try to stimulate the vagus nerve if they already have increased parasympathetic output.
Alrighty. And what is the best way to stimulate the thalamus and the hypothalamus?
Oh, the best way. So there are certain acupuncture points that just have a lot more research behind them than other points. And the points that I see over and over again in the research that have a big impact on the hypothalamus are pericardium 6 and spleen 6. And one of the point that I see having a huge impact on the thalamus is stomach 36 and large intestine 4. So those are kind of my, the points that I've seen in terms of the most research kind of consistently showing their effects on those particular structures. Obviously, we have thalamus point in the ear as well. And I will say when I'm using my pointer plus and that thalamus point lights up, I needle it. And I feel like that happens frequently with people that have chronic pain.
Right. Do you see as much impact of vagus nerve gut to brain, brain to gut from brain injury, from infection from things like tick-borne illness, from babesia or Bartonella, etc.? How does vagal nerve stim impact this?
So the tick-borne illnesses can have a huge impact on signaling. Those just completely wreak havoc on the nervous system for a lot of patients. Many of my patients with Lyme disease or other tick-borne illnesses have a lot of dysautonomia. And I talk about that in some of my other classes. And so again, I do base I base my treatments on what I'm seeing in my neurological exam, because for each individual patient, those tick-borne illnesses are going to impact different parts of the nervous system. And so you can't have just one protocol, because every single person with a tick-borne illness, infection, or inflammatory response, they're going to be affected differently, and there are going to be different parts of the nervous system and different parts of the brain that are uniquely impacted. And so that is definitely a phenomena that I see frequently in those patients and in that patient population. So I have to base what I'm doing on my individual neurological exam. There's a brilliant doctor, Dr. Sergio Azzolino in San Francisco, who just published a paper that showed that people with traumatic brain injuries, when he ran tests, there was a significantly large percentage of those people with brain injuries that also had some kind of tick-borne illness or infection. And so that's a fascinating finding, and definitely something that needs to be looked into further as well.
All right, and how are you doing on time? Are you okay to keep going with some more questions, or are you getting tired?
Let's take one or two more.
Okay, sounds good to me. If somebody has a concussion or brain injury, how soon can you start treating them?
I have worked with people as quickly as 2 or 3 days after, and that was partly because I worked with MMA fighters, and so they would come see me right after their fight. I also found that when I had people come see me within the first 2 weeks of their concussion, they got better really quickly. And the people who saw me 2 years after, it wasn't always that quick, and so I started to really wish that more people would consider, getting acupuncture very close, very soon after their injury, and not wait for 2 years or 5 years or 10 years. Certainly when people have a concussion or a traumatic brain injury, they can be in a very fragile, their nervous system's in a very fragile state. And so at that point, at those early on treatments, less is more. And a lot of times I'm not starting out with electro-acupuncture, during those, 2 weeks within the concussion or TBI. And I'm just doing, maybe a couple of auricular points, a couple of calming points, I'm keeping it very, very simple, and I'm keeping my treatments short. But I do find that the sooner I can work with somebody, a lot of times the better the outcomes.
All right. Let's see. Let's get one more question in here.
These are really, really good questions.
They are really good questions. And there's actually a fair amount more. Would it be all right if I sent them to you after the webinar, and then I can put them on our blog along with the recording?
Sure, that sounds great.
Perfect. So for anyone who asked a question, didn't get it answered, we'll get it answered for you. Let's see. Sorry, I lost my train of thought here. This one seems like a pretty good question here. Do you get good results without utilizing electroacupuncture?
The short answer is yes. I do a combination. Every single patient that comes to me gets a very different treatment based on what I'm seeing, again, in what I'm in my exams. And so everything I do with my patient is a dance. I'm seeing these neurological findings, I'm doing a treatment, and I'm expecting to see a change. And so for some people, if I can see a change without using electroacupuncture, and I'm seeing these changes and they're positive and they're getting better, great. For other people, they seem to actually respond better when I do electroacupuncture. And so there's just, I don't have, protocols that I apply to every situation, because every encounter with a patient is a new encounter and a new experience. And all I can say is that I pay very close attention to collecting enough objective biomarkers that I'm constantly checking back in with to say, are these biomarkers improving? Is my patient getting better? Is the integrity of their nervous system improving? And if so, then I'm going to keep doing what I'm doing. If it's not, I'm going to change my program. So, again, some people I do electroacupuncture with, and some people I don't.
All right. Well, I think that is going to be it for tonight. We have answered so many questions for us. Actually, if it were up to the attendees, I'm pretty sure we'd be here for the next 4 hours, because they really want more from you. So if you do want more from Dr. Wolf, please visit her website, which is acupunctureneurology.com. I am copying a link and putting it into the chat right now. There's also a link to that in the email that you all are going to receive 5 minutes after we end. And you do have a sale on a few of the classes that's going to be going on until August, if I'm correct.
Yep, end of August. And the sale's already there. They don't need a code or anything. It's automatically applied.
All right. Well, thank you so much for this incredible webinar. Thank you to everybody who joined us tonight. We hope to see you guys next time, and stay cool.
Awesome. Thank you, everybody.
Thank you, Dr. Wolf. Such a pleasure.
Great.
Thank you.